So basically, I've slightly modified the topic because coagulation disorders is a very broad kind of a topic, and I thought I'll restrict to thrombosis today, because I think that is something which is very important in your day-to-day practice, and as well as there are certain new things which need to be discussed. Dr. Sushma is requesting to annotate the shared content. So the topic outline would be, I would first try to tell certain definitions in relation to thrombosis. Then I would be telling the natural history of thrombosis. Then I would discuss a few algorithms regarding the diagnosis of DVT, and then algorithms regarding the diagnosis of DVT, pulmonary embolism, and superficial venous thrombosis. Then the later half of the topic, I would like to cover the pharmacology of the various anticoagulants, and then in the last, we can discuss certain case scenarios. So I'm getting this repeated messages to and requesting to annotate the shared content. What does that mean? Can anyone tell? So
you can ignore that.
Okay. So the first thing is that most of the when we are talking about thrombosis, the first thing which we need to know is that the most common site of thrombosis is the deep veins of the legs. So as we had all read in our anatomy, that this is the popliteal segment of the femoral vein in the popliteal fossa, and any thrombosis which is restricted below the popliteal fossa would be called as a distal deep vein thrombosis, whereas any venous thrombosis which is extending beyond the popliteal fossa will be called as proximal DVT. So these are the two things: distal DVT and proximal DVT. They both have different connotations and different risks for development of pulmonary embolism. So that is why whenever we so the other people can maybe mute if they are not unless they have certain doubts or something. Okay, so this distal veins and proximal veins, so this will help us in defining whether it is distal DVT or proximal DVT. So these are the general terms which we would encounter, and these are the definitions which I think all of you should be clear with. So VTE or venous thromboembolism is thrombosis that arises commonly in the veins, or embolism to lungs. So any deep vein thrombosis, whether it is a splanchnic vein, portal vein, mesenteric vein, upper limb vein, cerebral venous sinus thrombosis, or pulmonary embolism, all these entities together are in the kind of come under the umbrella of VTE or venous thromboembolism. Then there are two terms: superficial venous thrombosis and deep vein thrombosis. So these need to be differentiated because they will have different treatment approaches. So a thrombosis which is limited to superficial veins is called as superficial venous thrombosis, and which is and a thrombosis which arises in the deep veins, most commonly in the large veins of the legs or pelvis, that is called as deep vein thrombosis. Then the next is pulmonary embolism. So pulmonary embolism, as you all know, occurs when the thrombi dislocate from the venous walls and they pass through the heart to the pulmonary artery. So any thrombus which was there distally and now it has embolized and localized itself to the pulmonary artery, that will be called as pulmonary embolism. Then the next two terms are unprovoked DVT and provoked DVT. So unprovoked is when there is no identifiable provoking environmental event for the DVT which is evident. Okay, and so it is environmental. And provoked DVT is caused by a known event. So those provoking factors, they are usually classified into these four headings. One is the transient major risk factors, which means any major surgery which has lasted for more than 30 minutes, or hospitalization or immobility for 3 days, a cesarean section. Transient minor factors such as short surgery less than 30 minutes, pregnancy, estrogen, reduced mobility, air travel, all those things are transient minor factors. Then there are persistent risk factors such as a malignancy or an inflammatory bowel disease, which will be there for a few months to years, but after that it resolves. And then there are irreversible factors such as chronic heart failure, metastatic end stage malignancy, or inherited thrombophilias, which are going to be there throughout the patient's life. So these are the four. So basically, whenever we get a thrombosis, we have to qualify that whether it is a deep vein thrombosis or superficial vein thrombosis, whether if it is a lower limb deep vein thrombosis, then we also have to qualify whether it is a proximal DVT or a distal DVT, whether it is associated with pulmonary embolism or not, whether there is whether that deep vein thrombosis is it a provoked event or an unprovoked event, and if it is an provoked event, then what category of provoking factor is there, whether it is a transient factor, persistent factor, or an irreversible factor. So after that, what we basically next in the next few slides, what I would like to tell you is the natural history of deep vein thrombosis, because unless we know that, we will not be able to. Excuse me. Yes, Urmi. अच्छा, एक्चुअली मैं एक क्लास ले रहा था, सो कैन. हाँ हाँ. Yeah, I'm sorry. So basically, the natural history of DVT, first of all, we have to understand that most of these thrombi will arise in the calf area of the leg, which is that they will start as distal DVT. So, and majority of the thrombi which form in the deep veins below the popliteal trifurcation, that is called as distal DVT, and most of them will resolve spontaneously without any symptoms. So they will not even be noticed, and so these are all historical studies which were done on asymptomatic patients, and that's how we know that. So most of them will resolve. So up to 20% of the calf vein thrombi will extend into the popliteal vein or further proximally, and then we call them proximal DVT. And most of the patients uh, uh, become symptomatic only when the distal DVT extends to the popliteal veins and femoral veins or other proximal veins. It is only then that the symptoms of swelling, edema, pain, redness, all those will come. Okay, so extension of thrombosis is more likely to occur if the initial thrombogenic stimulus persists. Now, there is a 50% chance that the patients with an untreated symptomatic proximal DVT will develop pulmonary embolism within 3 months. So this is why it is important to timely diagnose a proximal DVT, because of the two patients of proximal DVT, one will develop a pulmonary embolism event within the next 3 months. So we should not be missing a proximal DVT. And pulmonary emboli, they'll be, if you just do a VQ scan of all the patients with DVT, almost 50% will have pulmonary emboli, and if asymptomatic venous thrombosis is found in 70% of the patients with clinically symptomatic pulmonary embolism. So this is the reverse. If you take, so a lot of time whenever we are requesting for a CT pulmonary angio with the radiologist, they would ask whether you got a compression Doppler done or not. So this is why, because almost 70% of the patients who have a pulmonary embolism will have evidence of DVT in the legs. So asymptomatic thrombosis is found in 70% of the patients with clinically symptomatic pulmonary embolism. So again, if the thrombus that embolizes is small, this generally happens if it is a case of distal DVT. The pulmonary embolism at that time may be asymptomatic, but in the long run, if there are repeated showers of small distal DVT emboli, it can cause cor pulmonale. So that is why whenever you have cor pulmonale, you have to see whether it is because of chronic thromboembolic pulmonary hypertension. Then pulmonary embolism symptoms such as new or worsening of dyspnea, chest pain, or sustained hypotension will occur only in 30 to 40% of the patients. So you have to understand that not all patients of pulmonary embolism will have symptomatic presentation. So symptomatic pulmonary embolism only occurs when the P is very large. So now, what about the mortality? Because that is what we are most concerned with. Navsheen, who's this Navsheen? Can he mute, he or she? So of the new cases of VT, up to 30% will die within 30 days, and another 20 to 25% will have a sudden death due to pulmonary embolism with no further treatment. And 30% of these will go on to develop recurrent VT. So again, there is a big study called as the ERIC study, which reported that there is a 10% 28-day fatality from DVT and a 15% fatality rate from pulmonary embolism. And if you have cancer and pulmonary embolism, then within 1 month, around 25% of them will die. So this is why it is important to timely diagnose and pick up DVT as well as pulmonary embolism. So now what will happen if you treat them? So we told that around 30% will die if untreated, but if we give them a timely prescription of anticoagulation, that will reduce the risk of death to 1.5% in patients with VTE or pulmonary embolism. So from 30%, your mortality has directly come down to 5% by just timely giving anticoagulants and diagnosing DVT or PE. So that's why it is very important. And if you somebody might argue, no, they will have the risk of bleeding. So the major bleeding events occur only in 1 to 3% patients who are on VK, who are on vitamin K antagonist. While with the newer, lower anticoagulants, the bleeding risk are again 30% lower as compared to VK. So the bleeding risk is very, very minimal, while the risk due to deaths is up to 30%. Death due to thrombosis is up to 30%. So that is why timely diagnosing DVT or PE is important. So this is the immediate mortality. Now, untreated DVT and PE can have certain long-term complications as well. So the two most important problems are, one is the post-thrombotic syndrome. So the PTS will develop in around 20 to 50%, which is like 1 in every 3 or 1 in every 2 patients will develop pulmonary post-thrombotic syndrome, and those patients will have limb pain, swelling, heaviness, edema. Their quality of life is very bad, and up to 5% of these PTS are quite severe and physically debilitating. That is one problem, long-term complication of an untreated VT. The second problem is that a residual thrombosis can act as a nidus for recurrent thrombosis. So whenever, if the patient has had a DVT now, there is a 1/3 chance that there would be another episode of DVT in the coming 8 to 10 years. So this is also so recurrence as well as PTS. These are two long-term complications. So the next question is, this is all about DVT, whether it is a distal DVT or a proximal DVT. So we kind of understood that distal DVT as well as proximal DVT, they are at a high risk of pulmonary embolism and mortality. But on the other hand, superficial vein thrombosis, so superficial veins of the legs are the veins which are just below the dermis, and these are the typically the great saphenous vein, the anterior tibial veins, those peroneal veins. These are all superficial veins of the legs, and and the femoral vein is often called the superficial femoral vein, but that is actually a deep vein because it is connected to the deep venous system directly. So this is the so the light blue ones are the deep veins, and the dark blue ones are the superficial veins. So, so of these, again, the great saphenous vein, although it is a superficial vein, but it is still has a very high tendency for its clots to progress to the deep veins. So again, GSV, superficial vein thrombosis, needs to be given a proper attention. So basically, with this background, we have to know that whenever we encounter a case of DVT, we have to identify whether it is a superficial venous thrombosis or a deep vein thrombosis. If superficial vein, what is the extent of thrombosis, where all it is happening, and if it is a deep vein, then what all veins are being involved. For that, we need a good imaging. So basically, whenever we suspect a DVT, we should always be using a clinical prediction rule to further kind of channelize our investigative strategy. So there are a lot of CPRs or clinical prediction rules which can be used, but the most commonly used and the recommended ones. So for DVT, you should always use a Wells score. So there are two Wells score. One is for DVT and the other one is for pulmonary embolism. And for pulmonary embolism, we also have a revised Geneva scoring. So based on these clinical prediction rules, you would be able to know whether there is a high possibility of DVT or a low possibility of DVT, and that would further help you channelize your investigations. We'll come to that in the diagnosis part. So before that, superficial venous thrombosis, we know that superficial vein thrombosis, basically, if it is within the trunk of GSV or the great saphenous vein, then it is more likely to progress to the deep veins. And we know that once the thrombosis progresses to the deep veins, they have a 1/3 chance of embolizing to the pulmonary circuit. So this is the diagnostic algorithm which you would use. So there is a patient who has come with, say, swelling of the legs or redness of the legs, and you are or with an immobilized patient who has come with a sudden onset shortness of breath or dyspnea. So you are clinically suspecting a DVT or a pulmonary embolism. You use the clinical decision rule, whether you use the Wells score or you use the Geneva score, whichever. And the rule says that the pulmonary embolism or the DVT is unlikely. then at that time, using that score, and then you will do a D-dimer. If the D-dimer is also normal, then you would say that, okay, I have ruled out a DVT or a PE, and you can just stop there, and you need not go for further investigation. You need not go and ask your radiologist to do a CTPA or a compression Doppler. However, if the scores clinical prediction rule says that the DVT or pulmonary embolism is likely, you would immediately go for a compression ultrasound for deep vein thrombosis or a CT pulmonary angio for pulmonary embolism, depending upon what you were suspecting to begin with. If it is negative, then you can just stop there. But if it is positive, then you need to basically um, treat the cause. So basically what this algorithm is saying is that if there is a low probability, you can use D-dimer to rule it out. If it has a high probability, then you directly go for a CTPA or a compression ultrasound. You need not do a D-dimer before that, right? So then once you have diagnosed DVT, the next would be the time frame for decisions for DVT or P. So basically, the treatment you can divide into three time frames. So the initial first 5 to 21 days is this yellow portion is the initial management, where you would stabilize the patient, you will give symptomatic relief, you will start him on anticoagulation, and you will give oxygen and all that stuff. So this is first 21 days. Then there is a primary treatment for 3 to 6 months. This is to stabilize the clot so that there is no further embolism. So this can range a minimum of 3 months to up to 6 months. So that is the primary treatment phase. Then after that treatment phase is over, whether it is at 3 months or at 6 months, depending upon whether it was a provoked DVT or a unprovoked DVT, you will again have to take a call whether I want to stop the anticoagulation or I want to continue it for secondary prevention. By secondary prevention, we mean recurrence. So that is called as the secondary prevention phase, and in this generally we end up giving indefinite anticoagulation. So these are the three treatment time frames. So whenever your patient comes with a DVT, you have to first of all know in what phase of therapy I am there. If it is a OPD patient, whether you are in the primary treatment phase or a secondary prevention phase, or if it is the emergency or a hospitalized patient, the patient is likely to be in the initial management phase. Okay, so these are the three phases. So just a very broad basic idea, which at least bare minimum which you should remember, is that for any provoked DVT or VT, you have to give 3 months of anticoagulation. For any unprovoked DVT or VT or pulmonary embolism, you have to give extended or indefinite anticoagulation. Extended anticoagulation is defined as no scheduled stop date, right? And then if there is any high risk thrombophilia which is there, then the duration of anticoagulation is lifelong. If it is a second episode of an unprovoked DVT or VT, then again your duration of anticoagulation becomes lifelong. And if it is a VT with cancer, then typically you will give the anticoagulation till the active phase of malignancy is persisting. And we can use either low molecular weight heparin or certain NOACs which are approved in cancer, but we will not use warfarin in those cases, or other vitamin K antagonists in those cases. So this is the algorithm which we will use for treatment of DVT. So whenever you confirm the DVT or PE, if it is an isolated distal DVT, then you just treat it for 3 months, and then you can generally stop it. If it was a distal DVT, irrespective of the fact whether it was provoked or unprovoked, right? Because but if if you feel that it is a high risk case, then you may sometimes continue longer. If it is a reversible provoking factor, then typically you will treat it for 3 months. You can use a DOAC or you can use low molecular weight heparin or vitamin K antagonist depending upon the affordability. Nowadays, most of the people would prefer a DOAC. If it is a first, so this is for provoked DVT. If it is an unprovoked DVT, minimum you will treat it for 3 months. Then after 3 months, you have to discuss it with the patient. You have to assess the risk benefit ratio of continuing anticoagulation or versus stopping anticoagulation. So if the bleeding risks are higher, then you will stop it. But if you feel there are no high bleeding risks, then typically you would continue indefinite anticoagulation for unprovoked DVT. Any second episode, you will have to give it a lifelong or an indefinite anticoagulation. Malignancy or pregnancy, typically you use low molecular weight heparin in these cases, but you can use DOACs as well, which are approved in this indication. So next, coming to pulmonary embolism, a lot of you would be working in the emergency. So you diagnose a pulmonary embolism. If the patient is hemodynamically stable, then you initiate anticoagulation. Then the next question which comes is whether we can discharge the patient or not. So for that, you should always be using a 30-day mortality risk scoring. So the PESI score, PESI, Pulmonary Embolism Severity Index, is a common tool which we can use. And if the PESI score says that it is low risk, you can typically discharge the patient. But if the PESI score says that it is high risk, you have to consider an inpatient treatment for next 2 to 3 weeks. Typically, you will have to shift the patient to the ward. So again, if there is if the patient is hemodynamically unstable, which means that there is shock or refractory arterial hypotension, then typically you will use a systemic thrombolysis followed by anticoagulation. And then in hemodynamically unstable, all patients, you will have to admit them to the ward. You just can't discharge from the emergency. So now this was all about DVT. What to do when there is a superficial vein thrombosis, which is like sometimes we get it in the upper limb, also there is a thrombophlebitis, or if in the lower limb there is only in the superficial saphenous vein or peroneal veins there is a thrombosis. Then once the steps would be, you first confirm that it is a SVT only. You rule out concomitant DVT or PE. Then you see that what is the extent of thrombosis. If it is within 3 centimeters of the deep veins, then it's better to treat it like a DVT, which is like 3 months or 6 months. If it is again within 5 centimeters, if it is less than 5 centimeters in length, it is a small uh, tributary which has a of thrombosis which is there. You can just use NSAIDs, you can use naproxen or ibuprofen, and you need not anticoagulate. So but if there is any superficial vein thrombosis which is within 3 centimeters of the saphenofemoral junction, which is long, which is more than 5 centimeter in size, or if the patient has any of these risk factors, that he's a male sex, he has cancer, or if it is in a non-varicose veins and there are no anticoagulation, no contraindications to anticoagulation, then typically you will give it for 6 weeks or 45 days. You can use a lower dose, which is like 2.5 milligram subcutaneous Fonda Perinox, or a 10 milligram of rivaroxaban can be used. So for deep vein thrombosis, the duration of treatment was 3 months minimum. For superficial vein thrombosis, either you don't treat it if there are no risk factors. If there are risk factors, you treat it for 45 days and then you can stop it. Okay. So so am I audible? It's actually very difficult to know whether you guys are sleeping, paying attention or not. So can anyone tell me?
Yes, sir, you're audible.
So this is Linta, right?
Yes, sir.
So Linta, just before I go further, can you name some newer anticoagulants?
Sir, apixaban, rivaroxaban,
Okay,
dabigatran,
okay. Any other? Any other volunteers? How do I show the participant list? Ajay, are you there? Ajay Gundiapati.
Sir,
So any other newer oral anticoagulants besides what Linta told?
Ipixa and rivaroxaban, sir.
What else? Joshi Anthony, our chairperson.
Edoxaban.
Edoxaban, okay.
Uh,
And so these are newer oral anticoagulants. What are the older anticoagulants? Joshi, you can name the conventional anticoagulants, right?
sir. Vitamin K antagonist.
Okay.
Heparin.
Vitamin
Hello.
K antagonist and vitamin K antagonists, what are their names?
Sir, Warfarin.
Okay.
Or
You have heard acetrom?
sir, acetrom. Ekam.
People are typing. Okay. So these are basically the anticoagulants which are there in our armamentarium for managing DVT or VT. So basically, so this is the table which is giving all these options. So we have unfractionated heparin, which is typically given as intravenous route. It has a half-life of 1.5 hours. So for the initial treatment dosing, you will give it as a IV infusion to target a APTT more than of 1.5 times the upper limit of normal, and you will have to monitor the APTT every 6 hourly till the time you are giving it. So unfractionated heparin is typically used whenever there is a high risk of bleeding or there is a thrombocytopenia, so that we can stop it immediately and reverse the effect. Then the second one is low molecular weight heparin. Typically it has a half-life of 3 to 4 hours, and you give it as a weight-based dosing. Then there is Fonda Perinox. Again, it is a weight-based dosing. It has a half-life of 17 to 24 hours. So low molecular weight heparin has a BD dose. Fonda Perinox has a OD dose. VK antagonist, you know that we give basically we always start it generally with 5 milligram dose to target an INR of 2 to 3. Debigatron, typically the dose is 150 milligram twice a day, and Debigatron and edoxaban, these are the two NOACs which would require a lead-in with 5 days of heparin. Also, VK antagonists also require a 5 days lead-in with heparin, whereas rivaroxaban, apixaban, you don't need a heparin bridge of 5 days, you diagnose pulmonary embolism, and you can just straight away start with a 15 milligram BD dose of rivaroxaban or apixaban 10 milligram BD, right? So these are the most commonly used NOACs. There is another one called as Bretrixaban, which has been recently approved. So obviously the mechanism of action, that's like quite basic. These are the direct thrombin inhibitors and factor 10A inhibitors. So where the drugs which are having an X in their spelling, such as rivaroxaban, apixaban, these are factor 10A inhibitors, and the Debigatron and edoxaban, they are like direct thrombin inhibitors. Okay, so this is the classification. Anti-10A inhibitors would be rivaroxaban typically comes as a brand name of Xarelto, apixaban comes as Eliquis, edoxaban comes as Lixiana, and Betrixaban comes as Bivaxa. So these all terms, DOAC, NOAC, TSO, targeted specific oral anticoagulant, TSOAC, these are all used interchangeably. Among the DTIs, these are the ones which are used as a parenteral route, typically in cardiothoracic interventions and surgeries like lepiridine, deciridine, bivalirudin, and arcatroban, and they are also used in HIT, whereas Debigatron is used in as an oral agent in DVTV. So ideal anticoagulant, basically it should be low cost, fixed dosing, there should be a rapid onset of action, and there should be a high efficacy with a safe therapeutic window with very less risk of bleeding. So basically Warfarin has a lot of problems with these, and that is why Warfarin is not, which was being used for past 30 to 40 years, is now being less and less used because it has a very variable dosing. So however, there would be few settings where warfarin and heparin is still preferable over NOACs, and you should know those. One is prosthetic heart valves, then pregnancy. Again, low molecular weight heparin is preferred because NOACs have not yet been approved in pregnancy. Renal impairment, we will see how in renal impairment what can be done. In severe liver disease, we typically don't use NOACs. APLA, because the trial showed that in APLA patients with thrombosis, if you use NOACs, there is a higher risk of thrombosis. So APLA is one condition where you would still use warfarin or acetrom for your oral anticoagulation and heparin for your parenteral anticoagulation, and you will not use the NOACs. Again, patients with poor compliance, patients with GI diseases, or if the patients are on inducers or inhibitors of glycoprotein or cytochrome P450, you would use the conventional anticoagulants over NOACs. Okay, so before we know when to start an anticoagulation, you should know the contraindications for anticoagulation. If the patient is having active severe bleed, if the patient is a known case of bleeding diathesis such as hemophilia, von Willebrand disease, if the patient's platelet counts are less than 30,000, if the patient has had an intracranial hemorrhage recently, or an intracranial or a spinal tumor which can bleed, or if the patient has recently undergone or is likely to undergo a neuroaxial anesthesia, then you should not be giving anticoagulation. Regarding the costs, basically around, so with the if you ask for, so warfarin costs around 150 per month, so that's a very like mud cheap drug. The generic NOACs will cost somewhere around 1,500 to 2,500 for a month, and the original ones will some cost us around 6,000 to 4,500 a month. So they are kind of affordable only. They are not very cost prohibitive, and so they can be used in most of our patients. So the dosing, I think you all guys know the dosing. Debigatron 150 BD, rivaroxaban you start with 20 OD for 3 weeks. Rivaroxaban typically has to be given with meals. That is something which you should remember, and apixaban 5 milligram BD. So this is again the dosing chart only. I'll share these slides and you can make a note from there. So certain few lines about Debigatron. So the Debigatron, basically it has a renal clearance, so we have to kind of take care, be a little bit cautious when we are using it in patients with renal impairment. That is one thing. The second thing is that the two drugs, Debigatron and rivaroxaban, they have a propensity for a higher risk of gastrointestinal bleed. So in patients who have a known peptic ulcer, or who have a GI polyp or ulcerative colitis, or anything, or a GI tumor, gastrointestinal malignancy, which is likely to bleed, in such patients you should be avoiding Debigatron and rivaroxaban. So rivaroxaban, as I already told you, should be given with food for proper absorption. Apixaban, again, has certain drug interactions, and edoxaban also has drug interactions. Betrixaban is the newer one which has just come up. It was approved in 2017. Again, here it is reversed, that it has to be avoided with high fat food. So this is the table of comparison of all the other things. So now what we need to remember is their elimination half-life. So it's all 12 to 14 hours for basically Debigatron, apixaban, and edoxaban, and around 5 to 9 hours in rivaroxaban, 11 to 13 hours in elderly. This is required because whenever we have to plan a surgery, or if the patient comes with a bleed, we have to see what was the last dose, which was when did the patient take the last dose, and accordingly we need to plan our reversal or antidote for that. So these are the FDA approved indications. They are all approved for VT, PE, extended therapy, as well as atrial fibrillations. So next, coming to monitoring of these drugs. Basically, for Debigatron, you have to basically know that your usual PT, APTT, and APTT are not going to help in your monitoring of NOACs. So this is one thing which we need to remember. So if a patient is taking Debigatron, the patient may still have a normal APTT despite having therapeutic level of drug, but very high or toxic levels of drugs are ruled out if the APTT is normal. So for Debigatron, the most sensitive test is a thrombin time. So even if there is a minor level of circulating Debigatron in the blood, the TT will definitely be prolonged. And if the TT is normal, then you can safely say that the Debigatron effect is over. Say for a patient of who's taking Debigatron, he comes to emergency with a intracranial bleed, and the neurosurgeon wants to operate, and he's asking you for a clearance. Then you can just do a TT. If the TT is normal, then you can safely clear the patient for the neurosurgical procedure. In rivaroxaban and apixaban, again, they have a very variable effect on PT and APTT. You can't use that for your monitoring. So you have to do NT10A levels, which are validated for rivaroxaban and apixaban. So these were the trials. If I don't think the DM students can remember the trials, or those who are this thing, but what you need to remember is that both Debigatron and rivaroxaban, they have a high risk of gastrointestinal bleeding, and these should be taken taken care of. This point should be taken care of when we are choosing the anticoagulant. So drug interactions, again, basically if you are taking drugs such as rifampicin, azoles, vincristine, tacrolimus, dexamethasone, cyclosporin, imatinib, anthracyclines. All these drugs will have interaction with NOACs. If it is a P glycoprotein substrate, it will interact with all the three drugs, Debigatron, rivaroxaban, and apixaban. If it is a CYP3A4 inhibitor, Debigatron, it's okay, but for the factor 10A inhibitors, they will have interaction. So always check for drug interactions with your interaction calculators on your mobile before prescribing these drugs. So when will the plasma levels normalize after the last intake? You have to, so if for Debigatron, they will normalize after 12 to 24 hours if the patient has a normal creatinine clearance, and then if the creatinine clearance goes down, then the clearance will be delayed. And for apixaban and rivaroxaban, generally, if the patient has taken the drug in last 12 to 24 hours, that's okay. So this question will come. So if a patient who has taken the rivaroxaban, say yesterday or day before yesterday, and he now comes to you with in the emergency and he's having a bleeding, so whether you need to reverse the rivaroxaban or not, or if the patient needs to go for a surgical procedure, you have to stop the drug this much hours before. That's why these hours need to be remembered. So whenever you have to plan an elective surgery, you have to first see whether it is a minor risk of bleeding surgery, low risk of bleeding surgery, or a high risk of bleeding surgery. So depending upon that, basically, if it is a low risk surgery, you will hold the Debigatron for 24 hours before, and for a high risk surgery, you will hold it 48 hours before. For apixaban, edoxaban, and rivaroxaban, again it is 24 to 48 hours. This is all presuming normal creatinine clearance. For lesser degrees of creatinine clearance, the timing will increase in case of Debigatron. For rivaroxaban and apixaban, it will still remain 24 to 48 hours only. Okay, so then there are certain dosing changes for Debigatron in renal impairment which you can take care of. This is how to transition. If the say a patient is on NOAC and now suppose he develops renal failure and you want to change it, then from VK to NOAC, or if the patient was started on Warfarin from a outside hospital and you feel that okay, he cannot comply with the INR monitoring, or if the INR is not being remaining in therapeutic range and you want to just shift him to NOAC and go, then you just stop the VK, you stop the warfarin, and as soon as the INR becomes less than 2, you start NOAC immediately. Okay, and if there is a reverse that the patient is on NOAC and you have to shift him to VK, he comes to you that okay, I cannot afford it anymore, or if the patient has developed renal failure or he has to be started on a drug which will interact with NOAC, then you just continue the NOAC and you start the loading dose of warfarin, which is typically 5 milligram. And as soon as the INR becomes more than 2, you stop the NOAC and you continue the warfarin. So planning the invasive procedure. Basically, you just stop the drug, and once the half-life is over, you can start the you can give the clearance for the procedure if it is an elective procedure. But if it is a emergency surgery, then we will have to basically reverse the drug. So basically, there can be two reasons when we need to reverse the drug. One is that if the patient comes with a emergency bleeding, or if the patient requires an emergency surgery. In those cases, we have to kind of see whether there is a effect of drug there or not. So for that, for Debigatron, as I already told you, you do the TCT or the thrombin clotting time. For apixaban and rivaroxaban, you will have to do a NT10 level, but again, the specific NT10 level may not be available widely. So PT, APTT, INR, they will not exclude the drug effect. That is something which you need to remember. It's not like if the patient is on Debigatron and the APTT and PT is normal, you can safely take the patient for the surgery. For Debigatron, you need to do TT. For Apixaban, Rivaroxaban, you need to do NT1011. So so if the patient with known DOAC exposure has a prolonged APT or APTT, it should be considered secondary to the drug until proven otherwise. And in emergent or life-threatening condition, tests for quantifying DOAC should be performed to aid in patient management. So basically, there is no reliable test to monitor these drugs like we have APTT in case of unfractionated heparin or INR in case of warfarin. So for reversal, whenever these patients come with bleed, you have to reverse the anticoagulant. So in general, the typical the mnemonic which you need to remember is HASHTI, which is hold for the dose of hold for the dose of anticoagulant, see whether I need to give an antidote or not. You give supportive management in the form of volume resuscitation or inotropes. You start them on local hemostatic measures such as tranexamic acid. You give transfusion if the patient has profusely bled, and you investigate for the bleeding source. So this is HASHTI. So so Dushyant Singh, are you there?
I'm with
So what is the antidote for warfarin?
vitamin K.
Okay, and what is the antidote for Debigatron?
So it is thrombin inhibitors. Sir, we can give transfuse the this um, FFPs. Hello.
FFPs, will they help?
Um,
So one is that you will use this HASHTI for all the patients, whichever anticoagulant, if the patient is there and he has come with a bleed, he or she has come with a bleed, you will HA hold this thing you will do. But there is a specific antidote, if anyone can tell, any volunteers? Kanav Khanna, is he there? So Rudra Narayan has typed, Divakar Reddy has typed. So idracizumab is the antidote for Debigatron. But you don't end up using the specific antidote in all the patients. So first of all, you will see whether it is non-urgent or urgent. If it is non-urgent, say the patient has come with a minor gum bleed, or if the neurosurgeon calls you that, okay, this is a patient, I need to operate him for a spine surgery for low backache, and the patient is on NOAC, so kindly do the reversal of the drug. So that is an elective thing. So for an elective thing, which is typically defined as procedure more than 7 days away, you only require stopping the drug. Urgent is, then urgent can be two things: urgent without bleeding and urgent with bleeding. If it is urgent without bleeding, then reversal is needed within hours. So in those cases, you may require substitution of clotting factors, which you told, whether it is PCC or FIBA or FFP. Or if it is urgent with bleeding, you in those cases, you will give clotting factors support as well as antidote. So antidote will be used only when there is urgency and there is an active bleeding which is going on, which has not stopped. So this is for warfarin. So a lot of time the patients will come in the OPD with a out of range INR in patients on warfarin, and the patient is taking warfarin and his INR has become 3.4. So you need not stop it, you just decrease the dose by 10%. You calculate the weekly dose of warfarin. Say if he was taking 5 milligram daily, then you calculate the weekly dose that comes to around 35. So you decrease the total dose by 10%, which is by 3.5 milligram. So so his weekly dose will now become 30 or 32. So somewhere, if it is between 3 to 4, you just hold one dose and decrease the subsequent doses of warfarin by 10 to 15%. If it is more than 4, then again it is only here when you will give per oral vitamin K. And only if it is INR more than 9, when you need to give either per oral or IV vitamin K. And but if still, you need not panic very much if the patient is not bleeding. On the contrary, if the patient is bleeding, obviously you will give IV vitamin K and repeat it every 12 hours as needed. And if the patient is actively bleeding, you will also give PCC, prothrombin complex concentrate, or FFP every 6 to 8 hours as needed. For heparin reversal, what is the antidote for heparin? Govind Raju. Is he there? Gurkamal?
Protamine.
Protamine sulfate.
Protamine sulfate.
And what is the dose of protamine?
Dose, no idea, sir.
You have never used that.
No, sir.
And 0.4 ml, 40 milligram. I don't know how they are calculating this. Okay. So from where is protamine made? Can anyone tell that? That's a very common MCQ, no? Fish what? Someone is saying an insect. So it is derived from fish sperm. Okay. Salmon, nikhil ho jala. Okay. So protamine sulfate, but if it is significant bleeding, you can even give recombinant Nova 7, recombinant factor 7A. So now coming to the NOACs. So basically, what are the options with us? It's not just FFP. The more than FFP, what are the better options are FIBA, factor 8 inhibitor bypassing agent, which is called as FIBA, or activated PCC, PCC or prothrombin complex concentrates, or Octaplex. They are all available commercially also, and they are available in PGI pharmacy also. We use them for hemophilia patients routinely with inhibitors, right? And then if you don't have those, then obviously FFP and cryo and Tranix are the other options. So basically then there are specific antidotes. The specific antidote idracizumab, we already told that it is for Debigatron. Adinaxate alpha, someone was typing, that is for factor 10A inhibitors, which means it is for rivaroxaban, apixaban, edoxaban, enoxaparin, and Fonda Perinox. And there is another new one called as Siraparantag. They are again for direct thrombin inhibitors. The problem is that they are very costly and sometimes they are difficult to get. Initially, when this Debigatron was newly launched, the company had made the idracizumab freely available. So if they had given that scheme that if anyone bleeds, you can just ring us and we will give you idracizumab, and we used it for 2 or 3 of our patients. So this is the dose which is given. You just can make a note of it. So this will reverse it within 2 to 5 minutes. The antidotes will reverse the thing within 2 to 5 minutes. These are idracizumab is a monoclonal antibody to Debigatron, whereas Adenoxate alpha is the inactive form of factor 10A that will bind to the inhibitors. So you always, for minor bleeds, you just continue the anticoagulant and you will monitor. And just check the dose, creatinine clearance, and see that if there are any other cause, or the patient is taking some analgesics, some other herbal medicines which are kind of increasing the propensity to bruises. So that is for non-major bleeding. You need not stop the anticoagulant. But if there is a non-life-threatening major bleeding, which is like the yellow zone, so if it is Debigatron, you will use the hash T, and you will basically see that when was the last dose given, and you just make sure that with normal renal function, within 12 to 24 hours, there will be normalization of renal function. You can use tranexamic acid, a little bit of FFP, and fluid resuscitation measures. Same for apixaban or etoxaban. This is for non-life-threatening major bleeding. But if these patients, if the patient lands up with a life-threatening major bleeding, say he's having hematemesis, and he has taken Debigatron, then you will do all the above measures, and you will give idracizumab, and you will give prothrombin complex concentrate, PCC or APCC. So either of those you can use. So basically, whenever the patient on anticoagulant is coming with a bleeding, you have to identify whether it is a minor bleed, whether it is a non-life-threatening major bleed, or whether it is a life-threatening major bleed, and that will decide whether you want to use one intervention, two intervention, or multiple interventions. So for renal impairment, this is the chart. You just have to know that basically Debigatron, there are dose modifications for Debigatron, as well as rivaroxaban. There are dose modifications which are there, and you can always check and prescribe. So cancer-associated VT, I think it's a long topic in itself. You can just remember that rivaroxaban and etoxaban are the two drugs which are now approved for NOACs, in addition to low molecular weight heparin. Warfarin is typically not used in cancer-associated VT. Pediatrics, you can leave. Thromboprophylaxis, basically you have to see what are the options of thromboprophylaxis. So there is pharmacological thromboprophylaxis, there is mechanical thromboprophylaxis, and then you can use both. So Jeffrey, what is mechanical thromboprophylaxis? Jeffrey Samuel, are you there? Jeffrey Samuel.
Sir,
What is
sir, some compression stockings and all comes under, and DVT pumps comes under mechanical thrombophylaxis.
Yeah, so these are the options that we can use only pharmacological, or we can use mechanical, or we can use combined. And then in pharmacological, we have enoxaparin, Fonda Perinox, unfractionated heparin, and we have NOACs. And so broadly, typically we should be using pharmacological only, and mechanical is only used when the pharmacological is absolutely contraindicated. They have done head-to-head trials. They say that only using pneumatic compression devices or DVT pumps, they do not alone prevent the occurrence of DVT. So this is about prophylaxis. Now, how do you define whether so there is a patient who's admitted in the say male medical ward for a liver abscess. Now, how do you define whether I should give him a DVT prophylaxis or not? So is there anyone who would want to take that call? Pranjal Singh, are you there?
Yes, sir. So we can use scores like Padua score for this prediction. Sir.
Which score?
Sir, Padua score, PADUA.
What is Padua score used for? Where do you use the Padua score? That's what I'm asking.
To decide if we should give anticoagulation in medically ill patients. Sir.
Okay. So any other? So you use it in all your patients, right? So, okay. So basically, there are risk assessment methods for VT prophylaxis. So you can use the Padua VT risk assessment score. And if the score is more than 4, then it indicates that the patient has a very high risk of VT. And so here the reduction in VT would outweigh the increased risk of bleeding with pharmacological prophylaxis, and you would end up giving the DVT prophylaxis. So basically in this score, if you read it carefully, reduced mobility has 3 points, and any active infection or a rheumatological disorder again has 1 point. So almost all our patients will have a VT RAM Padua score of more than 4, and most of our patients would actually qualify for a DVT prophylaxis. Reduced mobility is typically defined as being up and about for less than 30 minutes in a day. So if the patient is able to walk on his legs for more than 30 minutes, then we say that there is no reduced mobility. But if he is not walking for less than 30 minutes, then it is reduced mobility. So again, there are, for ICU patients, there is a different improve VT RAM score which is used. For medical wards, we were using a Padua score. The other thing is, if you are using the improve VT algorithm, then there are 2 scores. You will use it for bleeding, and the other one you use for thrombosis. So if there is a improved VT RAM score of greater than or equal to 2, you give prophylaxis. But if the bleeding score is more than 7, then you hold the prophylaxis. So now the last part is few case scenarios I would like you to take. So Renu, are you there?
Yes, sir.
Renu, can you read out the question?
Yes, sir. Your patient is post-operative day 1 following an elective total hip arthroplasty. He has no prior history of thrombosis and is on no regular antithrombotic therapy. So what would you recommend today for post-operative VT prophylaxis?
What is your answer?
Mm, Low molecular weight heparin.
Okay. Any reason why you chose that? Why not DOAC?
Sir,
Why do you want to give the patient a prick?
yes, sir, we can give a DOAC, sir.
So you can give DOAC, you can give low molecular weight heparin, you can give unfractionated heparin as well. Obviously, you will not give aspirin or warfarin. So basically, these are the recommendations for so basically for hip fracture, they say that it's always better to give DVT prophylaxis. Whenever there is a major surgery, you should give DVT prophylaxis. For lap chole, they say that you don't need a DVT prophylaxis because the risk is very, very low. And again, for cardiovascular surgery, there you have to kind of individualize the thing, but in most cases, you would end up giving a pharmacological DVT prophylaxis. In gynec surgeries, say uterine surgery, so pelvic surgeries have a very high risk of DVT. So you'll always give a pharmacological prophylaxis. Interp is a very minor outpatient procedure. They say that you don't need a DVT prophylaxis. Again, radical prostatectomy, they say that if it is a robotic procedure, that then you don't need a DVT prophylaxis. Now this is a second scenario. Sejal, are you there?
Yes, sir.
Sejal, can you read the question?
Yes, sir. This patient has been admitted with a moderate size subdural hemorrhage to the critical care unit. The neurosurgical team feels she's at high bleeding risk. There are no plans for surgery. What would you recommend for prophylaxis at this juncture? A. No prophylaxis is indicated as she is at low thrombotic risk. B. Mechanical prophylaxis only. C is pharmacological prophylaxis only. D. Combined mechanical and pharmacological prophylaxis.
So how do you approach this?
Sir, since patient has been admitted with moderate side subdural hemorrhage, so pharmacological prophylaxis is contraindicated here, so we will go ahead with mechanical prophylaxis only.
So so whenever you encounter this question that
Yes.
whether I have to start DVT prophylaxis or not, always use the objective method. The objective method is that you use the risk assessment methods. You use the Padua score, or you use the improve VT bleeding as well as thrombosis score, and depending upon that you take a call. So here you want to go with the option B, mechanical prophylaxis only, right?
Yes, sir.
Okay, so I also agree with you. So that's the thing. So this is the what do the guidelines say? So for patients with so if there is a low to moderate risk of bleeding, then you go ahead with prophylaxis. If there is a high risk of bleeding, then you don't give pharmacological prophylaxis. So there are basically they have done the studies and they have told that. So but what is important is that you should keep re-evaluating the bleeding risks periodically. Okay, so now again Sejal, take this question as well. This is in continuation with the previous.
72 hours later, 72 hours later, the patient remains stable. Her repeat CT had shown no change in the size of her hemorrhage. She is still in the intensive care unit and has limited mobility. The neurosurgical team feels she can receive pharmacological prophylaxis safely now. What would you recommend at this juncture?
What is your answer?
Sir, continue mechanical prophylaxis only.
Why? What is her thrombotic risk?
So now it is low.
No, thrombosis risk I am asking. She is likely to be bed bound. They are saying that she
Yes,
is in
sir.
ICU. She has mobility. She is critically ill.
Yes, sir. Padua score
Padua
will come
score.
out to be more than 4 only.
Okay, so which means that she would benefit from DVT prophylaxis. Now, what is her bleeding risk? The platelets are normal. This thing is normal. So she had come from a trauma because of which she had a bleed. Now, there is no further increase in bleeding. You have observed for 72 hours. You have
So,
done
sir, we can give UFH, sir.
UFH or LMWH. So efficacy
Sir,
wise,
UFH.
so
Sir,
efficacy wise,
efficacy wise LMWH, sir, but UFH will have rapid reversal.
So you are kind of a very. So again, here the bleeding risk is like quite low. Yeah, again with enoxaparin, hardly 0.5 to 1% of the patients bleed, right? So here I think LMWH is a safe enough option. The neurosurgical team has told that she can receive. The answer is in the question only. The neurosurgical team feels she can receive pharmacological prophylaxis safely now. So they feel that she will not bleed. They are telling it with their experience and all. So you can give LMWH. UFH is also a safe option if the family is very apprehensive, if they have renal failure, or if they are not affording, then you can give UFH as well. But I would probably give LMWH only.
Okay, sir.
So, Selva Raj, can you take this question?
Yes, sir. This 52-year-old female with the past history of asthma, diabetes, and obese, which she is taking medications of tiotropium, salbutamol, and metformin. Seen in the emergency department with swollen right cough for 4 days and no clear provoking risk factors with the elevated D-dimers. He had a diagnosis of proximal right leg deep vein thrombosis, superficial femoral and popliteal veins. No compression on compression ultrasound. You decide to treat this patient with low molecular weight heparin, bringing to a vitamin K antagonist. Consider her body mass 120 kg. How would you select her initial dose of LMWH? Dose should be kept at.
Okay, read.
Yes. Dose should be kept up at the highest available syringe size. Dose should be based on the actual body weight. Dose should be based on calculated ideal body weight based on the age, gender, and height. Dose should be adjusted by peak anti-factor 10A levels.
I should have hidden the answer. I forgot doing that. So what will you do? How much low molecular weight heparin will you give? The patient is of 120 kgs.
Sir, 0.1 1 mg per kg BT dose we have to give, sir. Means
So you use the actual body weight or the ideal body weight? That's what
ideal body weight.
Ideal body weight would be somewhere around 70 kgs. You will get 70 kgs. So whenever you are calculating dosing for LMWH, even if the patient is morbidly obese or if the patient is like very emaciated, you use the actual body weight only, and you don't use the ideal body weight. That's what, and you don't use a fixed cap dose like the syringe size comes for
Yes, sir.
0.8. So you will give a 0.8 plus 0.4. Two syringes you will use in the morning and two syringes you will use in the evening. So you'll have to give 120 BD based on her actual body weight only. This is what was asked here.
Yes.
Who else will take the last question? Siddhartha
I
Das.
will read, sir.
No, Siddhartha Das. Or maybe let the juniors. Shriyanka.
DVT 8 months ago. And
No, you are senior. Shriyanka is there?
Yes, sir.
Read the question. Shriyanka, can you read it aloud?
Yes, sir. Your patient had an unprovoked DVT 8 months ago and now requires a colonoscopy. What would you recommend for management of her VK anticoagulation around the time of her elective procedure?
Just
Post,
forget about the options. What will you do? Patient is on warfarin for a DVT which was there 8 months ago, and now she has to undergo a colonoscopy. What will you say?
depending on her INR,
First of all, you will stop the warfarin or not?
no, sir. Like we'll check her INR, and according to that, if it is within like acceptable for the procedure, then we need not stop it.
So INR is 2.2. She is a therapeutic dose, right?
Sir, can't decide.
Okay, read the options.
So postpone procedure by 4 months to lower VT risk. Interrupt VK before procedure and give peri-procedural bridging anticoagulation with LMWH. Interrupt VK before procedure and give peri-procedural bridging anticoagulation with unfractionated heparin. Interrupt VK before procedure and do not provide any bridging anticoagulation. Yes, sir.
So what will you do? Selva, you take the answer.
Sir?
So what is your answer after reading the options?
Sir, I'm sorry, I can't say.
Your seniors are kind of bossing you. Selva,
Sir, interrupt VK before procedure and give peri-procedural bridging anticoagulation with LMWH.
no. So basically, you have to understand that she had an unprovoked DVT 8 months back. So
Yes,
even if you stop it for 1 or 2 days, the risk of recurrence, so the recurrence of DVT maximum, it occurs in first 6 months only. So anyways, after 3 to 6 months of unprovoked DVT, we always keep on thinking whether we have to give indefinite anticoagulation or not, right? We always discuss it with the patient, and if they say that no, I don't want to take anticoagulation, then we kind of stop the anticoagulation. So here there is a very low to moderate risk of recurrent VT. So here you don't need a bridging anticoagulation. Say if it would have been an APLA case, if it would have been a antithrombin 3 deficiency case, or any case which has a very high risk of bleeding, in those thrombosis, in those cases you would have required bridging. In such cases, when there is a very low risk, you need not do a peri-procedural bridging with LMWH. This is what. So if you have to hold on warfarin, how many days before you will hold?
So at least 1 week.
That's too long, no? 5 days is fine.
5 days, 5 to 7 days. Yes. Okay.
And then you check the INR, and what INR you think it is safe?
Sir, less than 2 is safe, I think, sir.
Less than 2 or less than 1.5?
Sir, I'll check, sir.
1.5. Okay.
Yes, sir.
So these are this is the risk stratification for VT. There are certain high risk things like thrombophilias, APLAs, VT within past 3 months. Moderate risk is 3 to 12 months. Heterozygous factor laden, active cancer. Low risk is VT more than 12 months. So moderate to low risk, you can just stop the thing, do the procedure, and again restart the drug. Now this is, who will take this? Vinitha, are you there? I don't think she is there. Terence?
Sir. Say your patient who is on VKA for management of VTE has a large traumatic intracerebral hemorrhage. INR is 2.4. What would you suggest for reversal of a VKA anticoagulant therapy? A, IV vitamin K alone. B, prothrombin complex concentrate alone. C, fresh frozen plasma alone. D, IV vitamin K and PCC. E, IV vitamin K and FFP.
So, patient on anticoagulation has bled, right?
Yes, sir.
So this is a major bleed or a minor bleed?
It's a major bleed, sir.
Is it a life-threatening bleed or a non-life-threatening bleed?
Life-threatening bleed.
So whenever we have a life-threatening bleed, what is what is HASHTI hash T?
So we'll hold the anticoagulant dose.
Yes.
We'll A will consider antidote.
Okay.
As we can as we can consider giving FFPs or
Supportive.
PCs, supportive therapy, or if it's IV fluids or blood transfusion. H is for we can consider giving FFPs. FFPs we can consider giving FFP or PCC.
Hemostatic agents.
Hemostatic agent.
What are hemostatic agents? EMOPD में IC bleed के साथ आता है तो ट्रेनेक्सा लिखते हो?
Acid, sir. Trenexa we can give.
So here you actually, so in this patient, you need to immediately stop the bleeding, right?
Yes, sir.
Vitamin K takes how many hours to act?
Vitamin K will take at least vitamin K will act 2 to 5 minutes, sir. No.
No. Vitamin K takes 6 to 8 hours, no?
So, yes, sir.
So you have to immediately reverse it. FFP alone, no matter how much volume you will give, it will not be able to completely reverse it. So here the answer would be IV vitamin K with prothrombin complex concentrates. Okay,
yes,
FIBA or Octaplex, both are available in the market. Okay. So the answer would be IV vitamin K with PCC. So you can read the bottom line.
In patients with life-threatening bleeding with VKA during VKA treatment for VTE who have an elevated INR, the panel suggests using 4-factor PCC rather than FFP, in addition to cessation of VKA and intravenous vitamin K.
Okay.
Condition. Yes, sir.
There's one more. Swapnil Chaudhary, are you there?
Yes, sir.
Read the case vignette.
70-year-old male on rivaroxaban 20 mg daily for VT prevention after recurrent unprovoked pulmonary emboli, past history of hypertension, epilepsy, remission of anti-seizure medication from last 5 years, seen in emergency department with a frequent melena from 48 hours. Last dose of rivaroxaban was 4 hours ago. Hemoglobin has dropped from 12 2 months ago to 6 today. Blood pressure is 95/60. Heart rate is 1115 beats per minute. Diagnosis upper GI bleeding exacerbated by rivaroxaban.
So this is a major bleeding or a minor bleeding?
Major bleeding, sir.
Life-threatening, not life-threatening?
Life-threatening, sir.
So what will you do?
Sir, first of all, we'll stop. Will stop rivaroxaban, which has already been given 4 hours ago. Will first of all give vitamin K for only. Sir, will Adinexid alpha.
Emergency mein you have emergency duties?
Yes, sir.
Can such a patient come to you?
Yes, sir.
Oxaben is given right, left and center. In cardiology, in one OPD, they'll give some 10 to 15 rivaroxaban. In one hematology OPD, I write 2 to 3 rivaroxaban per day. What if the patient comes with a GI bleed? What will you do?
Sir, we'll
Vitamin
give
K doesn't work here.
sir. Sir, Adinexil alpha, but it won't be available, I guess. I guess. Is it available, sir?
Suppose it is available then. It's
So we can
available.
give.
It's costly, but it's available.
We can give it, sir, because the antidote for that is for
That is all.
rivaroxaban. No, so we'll give, sir, prothrombin complexes as well as FFP, sir.
Yeah, you give PCC, no? So you give, obviously you will resuscitate the patient, you will give fluids, you will give blood products because hemoglobin has gone down from 12 to 6. You will give tranexamic acid, you will give PPI 6 hourly, and you will give adenosine alpha as well as PCC or APCC, whichever is available. And at the same time, you will also investigate for the source of bleeding.
Okay, sir.
How
Yes,
will
sir.
you investigate that?
But upper GI, sir.
So you will get an upper GI done. That bleeding peptic ulcer needs to be cauterized, or if there is a varix that needs to be ligated, that also has to be done in next 24 to 48 hours. Okay.
Yes, sir.
So you will give cessation of anti-10A, you will give 4-factor PCC, and you will give adenosine alpha. So if the patient was taking Debigatron instead you would have given again PCC, idracizumab, and stopped this thing.
Okay, sir.
Now continue this.
Your patient receives 4-factor PCC and his rivaroxaban is temporarily suspended. He started on intravenous proton pump inhibitor. Gastroscopy reveals 2 by 2 centimeter ulcer with a visible vessel that is clipped and the patient bleeding stopped. He discharged home on no antithrombotic therapy to be reassessed at a later date.
Is the same patient like the one which we were discussing. Okay. Now this is the question.
This patient has been receiving anticoagulant therapy with a direct factor 10A inhibitor for recurrent VT. He has a recent upper GI bleed. How long after this bleeding event would you wait before resuming anticoagulant therapy?
So one is, will you resume or will you not resume anticoagulants?
The bleeding risk is high.
And what is the thrombotic risk? He already has had 2 recurrent VT, right? So he has
Yes,
had
sir.
2 episodes of VT.
Yes,
What is
sir.
the mortality with one untreated case of VT?
30%, sir.
So that's why. So there is a very high thrombotic risk. Bleeding risk we can calculate after 2. So immediately, obviously, for first 2 weeks you will not give it, but after
Okay,
2 to 4 weeks, would you your peptic ulcer has been clipped. That local cause has been taken care of.
yes, sir.
So will you restart on anticoagulant or not?
Sir,
So you
we
will
have to
restart.
restart because of recurrent VTs. We have to restart, sir.
Yes. So within 2 weeks to 3 months, whenever you feel that the patient is fine, you will have to restart him on anticoagulation. Now the next question is, which anticoagulant will you restart him on? What are the options with you?
Sir, DOAX, one option is DOAX, low molecular weight heparin and
Name, what
unfractional
are the
heparin, sir.
DOACs? Which DOACs do you have?
Sir, already he has Debigatron and rivaroxaban.
So Debigatron and rivaroxaban are bad for GI bleeds, to put it in absolute simple terms, right? So either you can use apixaban, edoxaban, or you can use enoxaparin. Obviously, no one will give a parenteral anticoagulant because he has to take it for lifelong. So the third option is you start him on warfarin. Okay.
Okay, sir.
So within 90 days, you should. So if the patient is receiving anticoagulation and they land up with a major bleeding, the resumption of oral anticoagulation should be done within 90 days. So basically, this is the conclusion. Although expensive, newer anticoagulants are safe, convenient, and efficacious in VT and atrial fibrillation. In malignancy, also they are being explored. Rivaroxaban and apixaban are already approved now. Targeted antidotes are still are developed, but reversal in case of a bleeding kind of still remains a challenge, and you have to be very active.